In severe asthma, in that case, then as I've already alluded to, the combination of blood eosinophils, so an eosinophil count more than 300 cells per microliter, along with an FeNO more than 50 parts per billion in a patient with severe asthma who's got GINA on GINA step 5 therapy, is very highly predictive of whether they are going to get frequent severe exacerbations over the subsequent calendar year. In that regard, FeNO and eosinophils will give you a very accurate prediction of whether the patient responds to certain biologics. FeNO will not give you a good readout in terms of predicting whether patients will respond to eosinophil suppressing treatment, for example, with anti-IL-5 therapy like mepolizumab or benralizumab, but it will give you a very strong prediction of response to anti-IL-4 alpha therapy, or indeed anti-TSLP therapy. So we're talking here about anti-IL-4 alpha with dupilumab or anti-TSLP therapy with tezepelumab. Then FeNO is a very strong predictor of response in terms of reducing exacerbations, and also with both of those drugs in terms of improving airway caliber as FEV1. But it won't tell you about response to IL-5, where in that case it's purely eosinophils. And the reason for that is that eosinophils are predominantly driven by interleukin 5, whereas FeNO is exclusively driven by IL-13. So any biologic which has an effect on the downstream IL-13 pathway, so either an IL-4 alpha blocker like dupilumab, or an upstream alarmin blocker like tezepelumab, will have an effect on FeNO. They'll suppress FeNO, so you can actually monitor whether the patient's actually taking the drug, which is quite useful. And at the same time, the level of FeNO will give you a good readout in terms of predicting the likelihood of getting a meaningful reduction in exacerbation. So I couldn't manage my severe asthma patients without having FeNO measurements at initial assessment and also at subsequent serial assessments in the clinic, because obviously we follow our biologic patients very closely indeed.